Hello friends, welcome to Raaonline. Today's topic of discussion is respiratory mechanics. There are multiple ways to discuss respiratory mechanics for an intensivist. Our focus today will be for respiratory mechanics in the pursuit of ventilator-induced lung injury prevention. How we are going to use respiratory mechanics to prevent ventilator-induced lung injury will be the major focus of our topic today. So what is respiratory mechanics? It refers to an expression of lung function through pressures and flow. It's an umbrella term for a variety of indices measured during mechanical ventilation. It indicates the energy transferred from the ventilator to the patient. So it helps us to understand the surrogates of lung stress. So there are a lot of ways in which the lung can be stressed when the patient is on a ventilator. It is by barotrauma, by volute trauma, and ultimately all these types of trauma lead to biotrauma. The injury is biological, but the stimulus is mechanical. Hence, respiratory mechanics is very important. It's a very important concept for the intensivist to understand. So, why should we monitor respiratory mechanics? As I already said, it has twofold purpose. One is to understand the severity of the disease. How severe is the lung disease? How much has it affected the lung complaints? What is the resistance? So, it helps us to understand the severity of the disease. The other purpose is to modify the inputs which we give through the ventilator, to modify the support which we give to the lung by basing the values of the respiratory mechanics which we have measured. So, the twofold purposes are to understand the severity and to use the data to modify inputs further. So, the ultimate goals will be optimizing the patient's pulmonary physiology, providing effective gas exchange, that is oxygenation and removal of carbon dioxide, maintaining alveolar recruitment, reducing injury potential, and ensuring hemodynamic instability. The most important thing will be to reduce the injury potential, less harm through mechanical ventilation. So, mechanical ventilation can produce both biochemical injury and biophysical injury. So, ultimately the biophysical injury in the form of shear, overdistension, repeated stretch, cyclic stretch, or increased intrathoracic pressure all lead to pathological correlates in the lung in the form of increased alveolar capillary permeability, decreased cardiac output. Ultimately, this leads to biochemical injury at the cellular level in the form of increased cytokines, complement release, leukotriene release, and production of reactive oxygen species. And this leads to neutrophil activation. When neutrophils get activated, all this is released into the systemic circulation as well. And ultimately what results is tissue injury secondary to inflammatory mediators which are released. And this tissue injury can cause impaired oxygen delivery. And impaired oxygen delivery can lead to bacterial translocation and bacteremia and ultimately multi-system organ failure. So, increased biophysical injury can lead to a downstream cascade of multiple events which ultimately terminates in multi-system organ failure. So, monitoring respiratory mechanics is very essential that we reduce all these effects, and we should match technology to patient's needs. So, the contents of my talk are going to be construction of the equation of motion, and getting to know the individual components of the equation of motion, which is very important in respiratory mechanics, and then a lot of other parameters which needs to be monitored during respiratory mechanics, and the new comers, the new parameters which are in vogue right now, and emerging other emerging concepts in ventilator-induced lung injury prevention. So, let's get to the equation of motion. So, what is the equation of motion? The equation of motion for respiratory mechanics, I would call it's like the Pythagoras theorem for mathematics, or the Euler's theorem in geometry, or the Newton's law of motion in physics. It's as important as these laws for ventilation. So, the equation of motion is the starting stone for, building stone, some basic building stone for the concept of respiratory mechanics. The equation of motion was first proposed by Rohrer. It's actually based on the Newton's third law of motion, and it refers to the relationship between the pressure in the system and the other parameters such as volume, flow, resistance. So we relate pressure to other parameters. See, when in a patient on ventilator, both the ventilator and respiratory mechanics can apply pressure to the respiratory system, and the sum of the applied pressure is equal to the sum of the opposing pressures. So, as I said earlier, both the ventilator, the pressure given by the ventilator, and the muscle, the pressure given by the respiratory muscles, this is the applied pressure. What are the opposing pressure from the lung? The pressure generated by the elastance of the lung, which is PEL, the pressure generated by the resistance of the lung, which is PRES, and the inertial pressure. So, in an ideal situation, this inertial pressure can actually be neglected because the effect of it is very small. So, this constitutes the fundamental theory of respiratory mechanics. We'll go to the individual components a bit later after looking at a few more concepts. So, trans pressures. What are trans pressures? When there is a cavity, the pressure, the gradient of pressures inside the cavity versus the pressure outside the cavity. The gradient of pressure inside minus outside gives the trans pressures. There are quite a few trans pressures which we have to understand with the airway. First is the trans respiratory pressure. This trans respiratory pressure is the pressure gradient between the atmosphere and the alveolus. So, this is the pressure gradient that allows the flow of gas in and out of the alveoli. So, next the trans airway pressure. This is the pressure gradient necessary to overcome airway resistance. This is the pressure gradient necessary for the air to flow through the large airways initially. So, only after the trans airway pressure comes the trans respiratory pressure. Then the trans thoracic pressure. This is the pressure gradient necessary to expand and contract the lung. This pressure, is the gradient between the pleural pressure and the body surface pressure. So, PL, plural, minus the body surface. Then the transpulmonary pressure. This pressure is the pressure gradient needed to maintain alveolar inflation. This is given by the difference between the alveolar pressure and the pleural pressure. So, the pressure acting in the airway level, at the airway level, is the trans airway pressure, which is the initial airway, which accounts for the initial airways, the flow inside the initial airways. And then the trans respiratory pressure, which is the pressure gradient which allows flow of gas into and out of the alveoli. Then the transpleural pressure, which is the pressure between the alveolus and the pleura, and ultimately the transthoracic pressure, which is the difference between the pleural and the body surface pressure. So, trans respiratory pressure is equal to trans airway pressure plus trans thoracic pressure. We can understand it in the next slide.